Thank you very much, Dr. O, ladies and gentlemen, fellows. It is my great pleasure to have an opportunity to contribute to this educational conference. My disclosure information. I would like to present 5 complex VT ablation cases in this time. What I learned a lot. The first one is the importance of cardiac vein mapping. The first patient was 15 years old boy with drug refractory symptomatic PVC with ejection fraction 50%. You can appreciate mild cardiomegaly compared to his age, and ECG shows the ventricular bigeminy, RBB morphology with long intrinsic deflection time and the precordial transition at V2 and 3. And also it shows the inferior axis, and lead 1 shows a very deep S wave or Q wave. So what does this PVC come from? You can estimate. So we brought the patient to the EP lab. In the EP lab, but the PVC morphology differs a little bit from the ECG from our outpatient clinic. So what does it mean? This PVC may have multiple axes. So ECG shows the LV outflow tract with long intrinsic deflection time and multiple morphologies. All those are bad news and suggesting epicardial multiple axes. So before entering the epicardium, a coronary vein map is very useful for planning the strategy. You can map the potential epicardial targets and even inaccessible sites, including septal veins or communicating veins in between outflow tracts. And coronary vein map with microcatheter provides a good landmark during ablation, estimating the location of coronary arteries. Even you can use coronary vein for alcohol ablation. So I recommend mapping the coronary vein for VT ablation, especially from LV summit area, basal anterolateral wall area, or crux areas. In this patient, the absolutely earlier activation of PVC was mapped from the anterolateral branch of a great cardiac vein here and here, but not inside the endocardial map. These are CARTO endocardial maps. The earliest activation site was diffuse here and here, not a discrete activation. So we mapped the endocardial area carefully with ablation mapping catheter, and you can appreciate far field V potential near the epicardial earliest activation site. So when you map the intramural or epicardial foci from endocardial side, you have to carefully observe the far field potential like this. But I could not find a better endocardial activation site than this point. So I can ask you, will you try to burn here or not? This one and this one. I did. I used half normal saline, 45 watt, 2-minute duration. But as you expected, there was absolutely no change. This is a decision tree provided by Garcia. You can try endocardial ablation at the earliest activation site if it is endocardial focus. If it is intramural focus, a coronary vein map is useful, and you can start the endocardial ablation as opposed to the earliest activation site. If it is a subepicardial focus, you need to map the corresponding endocardial site first, as I did. If wall thickness differs within 14 millimeter and activation time differs within 7 millimeter between endo and epi, you can try endocardial ablation first. Otherwise, you have to consider epicardial or coronary vein ablation. So in this patient, the activation difference between endo and epi was less than 7 milliseconds, but probably the separation was longer than 14 millimeters. I showed it later. So what is the next option? There are so many options: bipolar, simultaneous unipolar ablation, alcohol ablation, radio, epicardial ablation, surgical, and cardioneural ablation. In other words, there is no proven best option. Because nobody wants to generate a big scar in this young man, I chose epicardial ablation instead of an extensive burn. And Using the pentoric catheter, we found the earliest activation site and the epicardium here, minus 30 milliseconds earlier. And this is CARTO Epicardial Map. There was a discrete activation site nearby the global tissue area. I do not know whether it is the real scar or the epicardial fat, but there was a very low voltage potential, minus 90 milliseconds earlier than current onset. In this EGM, the proximal electrode was a little earlier than the distal electrode. Therefore, it may be near the coronary vein mapped site. So I decided to burn at the epicardium. Before RFN delivery, what should we check? Mandatory. Two things. It is mandatory to check coronary angiogram, and number two, Phrenic pacing. Coronary artery was separated enough from the VT target site. However, especially in the condition under general anesthesia with neuromuscular blocker, you have to be very careful about the Phrenic injury. Because I felt Phrenic capture at the target site, I carefully moved the ablation catheter to the safe place a little bit. However, I experienced Phrenic capture during RFN's delivery. It was not a pacing-induced Phrenic capture, but the RFN-induced capture. So what should we do? Next step. It is dangerous area. There are two ways to avoid the Phrenic injury in this situation. The first one is filling the pericardium with saline 80 to 150 milliliter. If Phrenic capture threshold is less than 5 MA, you can try this method. But if capture threshold is higher than 5 MA, or there is still risk of injury after filling the pericardial saline, you need to use large volume to separate epicardial surface from Phrenic. We could eliminate PVC at the epicardial target site after pericardial saline filling, and we finished the case with happy ending. As I mentioned, the separation between endo and epi was 90 millimeters, so it is greater than 40 millimeter. That's why we failed the first ablation from the endocardial side. Okay, next 4 cases will be sicker and riskier patients. This is an isolated cardiac sarcoidosis case. 68 years old gentleman experienced his first VT event 10 years ago, and then we underwent VT ablation 3 months ago, but the VT recurs, VT number 2. So he had a history of hypertension and proximal atrial fibrillation. Echo shows ejection fraction 45% with increased NT-proBNP, and the coronary CT scan was normal. At this moment, we suspected isolated cardiac sarcoidosis after evaluating the cardiac MRI. MRI shows the subepicardial and mid-myocardial scars, especially in the basal septal area, and T2 scan shows a similar finding. Because cardiac MR LG pattern was compatible with minor criteria of cardiac sarcoidosis, we checked FDG PET-CT, and you can appreciate the cardiac involvement of FDG. So to have tissue diagnosis, we conducted the CT and bronchoscopy, but there was no pulmonary lesion. So we did electrogram-guided endomyocardial biopsy, and although the pathologist mentioned the focal histocytic and lymphocytic infiltration, there was no granuloma in the tissue. Therefore, we failed to tissue diagnosis in this patient, but we could diagnose isolated cardiac sarcoidosis based on Japanese guidelines. Because the yield of endomyocardial biopsy is very low, some group proposed their EGM recording at the tip of biotome by connecting the electrode cable to the biotome. Nogami group proved the majority of VT mechanism of cardiac sarcoidosis are scar-related macro reentry, but 11% shows the vascular reentry, and non-reentrant mechanism also exists, and about 5% of VT patients with cardiac sarcoidosis. This is a sarcoidosis experience in my institute. Among over 573 patients with sarcoidosis, cardiac sarcoidosis was diagnosed in 3.8%, and ICD implantation was done in 2.4%. In the sub-analysis, reduced ejection fraction, late gadolinium enhancement positive, associated AV block, and appropriate ICD shocks shows the worse survival outcome than their counterparts. Case 3 is a genetically diagnosed non-ischemic VT with LMNA and the TTN mutations. This patient already had a CLT defibrillator with ejection fraction 35%, but had recurrent ICD shocks. This is the documented ECG patient brought to the hospital. He underwent first VT ablation from another hospital, but we did multiple further procedures after referral. VT targets at the first and second procedure were at the LB summit area, but also ablated the skull border zone at the mid-posterior septum. Final ablation was done at the mid-anterolateral epicardial side. Although the frequency of ICD shock decreased remarkably, but he still has occasional ICD therapies, so we included him in the transplantation list. This patient showed so many different VT morphologies. This is first one, totally different, 2, 3, 4, 5, 6, and 7, maybe further. It has been proven that the outcome of VT ablation in patients with cardiac sarcoidosis is very poor. And in these studies from Stevenson Group and International VT Collaboration Study Group, sarcoidosis shows a very poor rhythm outcome after VT ablation along with HCM or valvular VT. But the outcome of VT ablation in patients with genetically associated cardiomyopathy, such as LMNA mutation, is even poorer. Therefore, VT patient with cardiomyopathy younger than 50 years, VT patient with cardiomyopathy younger than 50 years old are the class 1 indication of genetic analysis. It is revised guideline. So close collaboration with heart failure team is also mandatory for managing those sick patients. Now, I would like to discuss the anesthesia issue. This patient with dilated cardiomyopathy was referred due to recurrent ICD shocks, and sinus ECG shows a CLT pacing, but QRS is relatively wide, and VT ECG brought from another hospital suggested LB summit or basal anterolateral wall region, mono VT, common side of DCM related non-ischemic VT. We carefully conducted endo and epi map, and unfortunately, however, we could not induce clinical VT at all. The patient was under gas general anesthesia, which could suppress VT induction. And also, substrate map could suppress clinical VT. Therefore, we had no choice and conducted the endocardial ablation at the LB outflow tract scar area. We finished the case after confirming no further induction of VT with aggressive pacing protocol. Stevenson reported sophisticated mapping of peri-aortic VT in patients with non-ischemic VT, and peri-aortic VT substrate were mappable in 38% of non-ischemic VT. Moreover, the proportional VT shows the LBVB and RBV pattern were half and half. In case of LBV pattern, it was easy to terminate, but shows a high chance of heart block. LBVB means it comes from septal side and nearby the conduction system. In contrast, in case with RBV pattern, the VT target exists more laterally and shows only 70% chance of termination due to deep intramural substrate. Unfortunately, our patient came back to emergency room because of VT storm a few months after the procedure. At this time, VT morphology apparently differs from the previous ablation. It is superior axis comparing to the inferior axis before. We could VT originated from mid to basal posterior septum and conducted scar dechanneling here This time, we used IV sedation during intubation status. After the disappearance of VT, we conducted a pacemap-guided procedure to exclude the risk of VT suppression again by anesthesia. Currently, he's okay without ICD therapy. The last but most important issue might be heart failure management. Case 5 was 78 years old male patient with dilated cardiomyopathy and VT with multiple morphologies, like this. So as you expected, this patient had multiple patch scars and multiple VT foci. Therefore, I kept following the change in VT morphology and ablated extensively, including epicardial. Finally, we finished the case after confirming no more induction of ventricular tachycardia. The patient recovered in the CCU after the procedure. However, his heart failure was decompensated after extensive ablation. So therefore, we eventually implanted LVAD after 3 months of this patient. UPenn group suggested PACE score, including COPD, AG, ischemic cardiomyopathy, heart failure, storm, and diabetes. And 30-day early mortality after VT ablation with heart failure is known to be about 5%. However, early mortality is even higher in patients with PACE score over 15. Because blood pressure and circulation become very poor after VT induction, you need to carefully monitor cardiac output, arterial pulse, pH, or lactate level. Percutaneous LVAD, this one, this one. We call it Impella. It's very useful in patients with hemodynamic instability, and Della-Bella provide this decision tree. The problem is early weaning of Impella LVAD could result in decompensated heart failure. Therefore, cardiac output, pH, or lactate monitoring is essential for those high-risk patients. This is my take-home message. Careful watching for far-field signal is the key to targeting intramural or subepicardial VT. Coronary vein or epicardial map may visualize intramural VT target, and underlying pathology of non-ischemic VT determines the prognosis of VT ablation. And general anesthesia may suppress the clinical VT induction, and pain score or ECMO backup could be helpful for safe ablation. Thank you very much for your attention.